Devin says in this paper that the incidence of osteoarthritis and lumbar spinal stenosis is increasing in our aging population. Their subjective complaints can be very similar. It can be difficult to identify and differentiate between hip pathology and lumbar spinal stenosis. When a patient reaches 50% improvement, or if they plateau or they're not responding to treatment, you'll be amazed by addressing the hip and treating the hip with any of the protocols for the hip decompression, how it helps with their back pain as well as leg pain. In this paper by Lee, it tells us that 1 in 3 patients that have had spinal surgery have hip pathology, and it may be even greater than that. This is how I got into treating the extremities using the Cox instrument. I noticed that my patients with spinal stenosis and lumbar radicular pain or disc herniation were responding a lot faster than patients with hip pain or knee pain until we developed these techniques or these protocols for treating those extremities. Up until then, it was quite frustrating not being able to get the same results. So traditionally, groin pain is associated with hip pathology and buttock pain is associated with lumbar spine pathology. But there is a lot of overlap in this paper. This was back in 1990 by Fogel, but you'll find that traditionally the groin pain is where patients have a hip issue. When I first came across these 2 papers by the same author, I was kind of scratching my head. I thought they were kind of speaking against each other. But when I read them more in depth, I found that the important message here is that a differential diagnosis is so important during treatment, not just waiting until they have surgery and prior to surgery. That way we address the proper complaint or problem and probably would get better results. I think this is useful information for our patients in decision-making process. These next 3 slides highlight a study done by Rainville last year in the journal Spine. It was an online poll of over 50 musculoskeletal physicians on over 80 different signs and symptoms that patients have, whether it's lumbar spinal stenosis or hip osteoarthritis, and took the most valued signs and symptoms to help determine or help in decision-making process as to the origin or where the pathology for the patient exists. And the 3 most likely symptoms that favored lumbar spinal stenosis over osteoarthritis of the hip were pain below the knees, leg tingling or numbness, or pain or some pain in both legs. For the hip, there were 8 symptoms that favored hip osteoarthritis over lumbar spinal stenosis: groin pain, knee pain, and the list is there. So there is some overlap, but there are some discernible signs and symptoms that we should be aware of when diagnosing our patients and treating them. Symptoms that did not help in discerning between the 2 some of them were a bit of a surprise. The shopping cart sign typically is a sign of lumbar spinal stenosis, but it also is a factor in hip osteoarthritis pain, back pain as well. So some of these were pretty surprising to see, especially with what we're accustomed to. So types of hip pain, just by location, the anterior hip, we're looking at osteoarthritis of the hip, neck fracture, septic arthritis, femoral acetabular syndrome, and avascular necrosis. Lateral hip pain, typically attributed to greater trochanteric bursitis, gluteus medius or minimus tendinopathy, peripheral nerve entrapments, and external snapping of the hip. Posterior hip is typically attributed to piriformis syndrome, Goic syndrome, sacroiliitis, lumbar radiculopathy, or referred pain. This paper by Cooper highlights gluteus medius weakness in patients with low back pain compared to the unaffected side or compared to controls. Trendelenburg sign is positive, and Trendelenburg gait may also be present. And that usually is indicative of either a weakness to the muscle or a tear. So in this case study, this is a coach that I coach with in high school football here in Windsor, and I noticed that he had back problems. He had told me years ago that he had 2 surgeries in his spine back in the 80s and 90s, decompression surgeries. He's had both knees replaced and 1 hip replacement, and it was the left hip. He was showing up to practices a lot less and less over the last couple of years, and in games he would just come out after halftime or sometimes just for part of the 4th quarter. He didn't really stick around much, and by the time he finally came in the office, he had told me that because of the fatigue that would happen in his back, his unsteadiness, he was prone to falls. So he came to see me about 2 years ago, leg pain mostly in the anterior thighs, and then when it would be real bad, it would affect his calf muscles as well, and his back would be very fatigued and tire out. He had several falls in the past couple of years. You can see his history there that I had already discussed. So we did protocol 1 on him, lumbar spine. My contact points based on his x-rays, which you can see here, were T12, T8, cervical spine, we did foramen magnum pump and contacted C4 and T4. Within 3 treatments over 2 weeks, he had 50% improvement. After that 3rd treatment, a few days later, he fell again. His pain was a 9 out of 10 on a numeric pain scale, and he felt that he was more unstable. His low back felt very weak. Took 7 treatments over 2 months to get him down to a 2 or 3 out of 10. Then we stopped treatment for a while, and he would come in every once in a while, so he really wasn't following a plan. You can see on the x-rays there, he's got a retrolisthesis at L3, L4, and as well at L4 and L5. As you can see the fusions at L2 and L3. You can see the hip replacement, and not to mention he's also had both knees replaced and shoulder surgery, which he was not aware of what was done then. We're going to speed up. So these are his flexion and extension x-rays. These were done in 2019, a year ago. So through the football season, again, we didn't see him that often. He wasn't as compliant as I had hoped he would be. But then he came back in just this past June, just 2 months ago. And everything was back to square one, he said. His back was very weak. He no longer did his groceries. He no longer cut the grass. So we did Cox Protocol 2. This time we contacted L1, and we included what I call Cox Protocol 3 for the hip. I'm not sure if I'll be able to get to demonstrate that today, but I will have the videos of Protocol 1 and 2 available. Cox Protocol 3 is something kind of new over the last couple months, so I'd like a little more time before I demonstrate that one. So after 2 weeks, again 3 treatments, he felt 50% improvement. He felt more stable on his feet for longer periods of time. He was able to go for walks longer. He was cutting the grass about half the time one day and half the next day, or he would do it with his grandson. But he does walk around the block now more often, and he goes grocery shopping again. So by the time we were doing treatments 4 to 7, they were falling 5 to 7 days apart. 2 days before treatment 7, he fell, but his back and hips were fine, even though he had a major bruise in the hip and down into the thigh. But we got him back in shape. Now he is more compliant. He comes in roughly every 2 weeks for a treatment, and he's doing really, really well. This was from 2 years ago, 87-year-old patient. She lived alone, and her brother was concerned because of her pain was increasing in her legs, and he was concerned about her safety being alone. So her pain in her hips was chronic. It had been there for a long time. But she developed, prior to seeing me within about a month or two, sciatic radiculopathy. So she finally came in, and her pain was down to her calf. The right hip pain was there, palpable, but the leg pain, the radicular pain, was greater than her back pain. She had a flexed antalgia, slightly to the right, in my opinion, and unsteady and shuffling gait. She couldn't tolerate standing more than 3 to 5 minutes and couldn't walk further than 25 or 50 feet. Getting into my office was a challenge. She would sit in the waiting room, even though I was ready to bring her in, just for a second, just to reduce the pain in her legs. Her numeric pain score was an 8 out of 10. Reflexes were normal, slightly hyper-responsive L4 on the left side. Kemp's and Bechterew were positive, the only positive tests that we found. Due to mobility and pain, though, we couldn't perform any of the supine tests, like straight leg raise and gold weight. So we did find palpable pain in her buttocks, all 3 gluteal muscles, piriformis, TFL. The IT band was tight all the way to the knee, and the hamstrings were both tight, and calf muscles. So we did protocol 1 on her lumbar spine, contacted L2, protocol 1 of her right hip. We recommended a brace and daily exercise. Her low back pain and sciatic pain resolved after her second treatment. That was quite surprising. She was in a lot of pain. Her right pain improved to almost 50% after just 2 treatments as well. So we continued with protocol 2 at L2, and as well protocol 2 of the right hip. And her numeric pain score dropped to a 1 or 2 out of 10 in the right hip after 4 more treatments. Her low back was a 0 out of 10. So we were quite happy about that, and she's still living on her own and doing well. When we're doing the hip, and it's, I guess when we're doing the hip, I notice patients when they get up feeling great. It can be a little tender, especially protocol 2 in treating the hip, but when they get up, they feel great. And I know that when we treat the spine, they feel great too. But when we don't treat the hip and we only treat the spine, they don't get up as well as patients that require both. So I think that's important to look for. These 2 cases highlight the relationship between hip osteoarthritis and lumbar spinal stenosis. The key message I'd like to get across is being able to identify and differentiate between the 2 conditions and treating both, and in most cases, treating both at the same time. So we're going to move on to the knee now. 5 to 17% of injured knees have a rapid progression of structural damage from normal to end-stage disease within 4 years. That's almost 1 in 5 patients. Individuals with a history of joint trauma are 3 to 6 times more likely to develop knee osteoarthritis and are diagnosed approximately 10 years earlier than individuals without a history of joint trauma. The average age of the patients in this study was 60 years of age. But that cascade of degeneration after an injury to end stage can be as quick as 1 year. This was published in 2015 by Favero. It says there is no therapy shown consistently to delay the progression of knee osteoarthritis. Some of the other highlights from this study are ACL rupture and meniscal tear are 2 major risk factors. I think that's something most of us are aware of for developing osteoarthritis. Partial meniscectomy increases the risk of osteoarthritis by 4 times as assessed after 16 years post-surgery. By the time the first knee joint changes are detected by radiograph, more than 10% of the cartilage is already lost. These 2 papers were published 25 years apart, but they both state the same thing. Its functional capacity of the patient is better in terms of setting up a treatment plan and management and prognosis for the patient versus imaging alone. Eaton and Drybem published this paper in 2017. Contrary to what Favero said earlier in the slide, saying there are no therapies to consistently slow down the progression of knee osteoarthritis, that oral glucosamine can directly affect the cartilage matrix, slow down degradation. It facilitates cartilage synthesis and recovery of chondrocyte matrix, of the chondrocyte matrix. I recommend it to all my patients. I recommend it from day one. And if they follow the guidelines, the recommendations for the proper dosage, combined with doing the decompression, it doesn't matter if it's the knee or the hip or the spine, all the joints improve. The results of this study showed that pain, joint stiffness, joint function scores, and total scores from WOMAC scale are significantly reduced between taking glucosamine and the non-steroidal anti-inflammatory Arcoxia. Not sure how long a patient can be on that NSAID, but it's interesting to see what the improvements were in these patients. We see it's pretty impressive. You get an increase in growth factors, in transforming growth factor beta, insulin-like growth factor 1, fibroblast growth factor 2. You get a decrease of inflammatory factors, a decrease in interleukin 1 beta, interleukin 17 and interleukin 18, as well as a decrease in tumor necrosis factor alpha. You get a decrease in matrix metalloproteinases, the enzymes that catabolize or break down that extracellular matrix. Your mixed metalloproteinases 3, 9, and 13. It's pretty impressive results from there. Most of the time on MRI, the size of the lesion in the knee is frequently underestimated by MRI. On average, they were 65% larger when going in surgically versus what they saw in the MRI, but could be as high as 377%. So this paper by Abram tells us that patients going for arthroscopic chondroplasty are at greater risk of subsequent knee replacement. And in a good proportion of the patients, the chondroplasty is unnecessary. It has no benefit for the patient, and they typically require knee replacement a lot sooner. In this paper by Abram, the proportion of patients undergoing total knee replacement within 1 year after partial meniscectomy increased by 141% between 1997 and 2016. There appears to be an urgent need to implement processes to reduce inappropriate arthroscopic knee surgery in the UK. Patients with lateral compartment knee osteoarthritis during arthroscopy are at a higher risk of subsequent knee replacement. In this study by Dale, patients with osteoarthritis of the knee who underwent physical therapy had less pain and functional disability at 1 year than patients who received intra-articular glucocorticoid injections. And they're pretty impressive results between the two groups. But the one thing is, they're not doing Cox decompression of the knee. The Cox instrument makes the treatment very easy on the practitioner as well as the patient. It's also a good shoulder and upper back workout. Could you imagine the results of a study across multiple clinics with Cox extremity adjustments? I guess I'd like to say get involved. Participation of just 10% in this program of physical activity highlighted in this study was able to save over 200 cases of cardiovascular disease, 400 cases of diabetes, and almost 7,000 quality adjusted life years in the patients. We need to get our patients moving. We need a proper standard form of exercises for our patients. I do find that PRP injections to be more effective for patients rather than cortisone. It does take longer to show improvement than cortisone does, but the outcome is better and lasts longer. I do recommend to my patients that come in for Cox knee decompression to wait a minimum of 2 to 4 weeks after a PRP injection, even though we already know that decompression does stimulate chondrocyte activity. This paper shows improvement in patients of proteoglycan content, histologic changes, macroscopic changes, and improvement in collagen damage with surgical knee joint distraction. This is a device that the patient would wear for 6 weeks, followed by 12 weeks of rehabilitation. This is a paper by Chen. It's pretty interesting. Despite recent medical advancement, to date there is no effective therapy that can reverse or halt the progression of osteoarthritis. And Chen states, we demonstrated that joint distraction reduced the level of secondary inflammation, cartilage degeneration, and subchondral bone aberrant change. Joint distraction may be a strategy for slowing osteoarthritis progression. I think most of us that do joint distraction do know that already. The paper goes on to say that joint distraction enlarges the knee joint space, similar to what we see in the spine, downregulates interleukin-1 beta activity, it attenuates cartilage degeneration, and reduces abnormal bone formation. This paper here by Braun and Dragu, when you showed that when you combine lidocaine with corticosteroids, you get up to 80% chondrocyte death in vitro. That's why cortisone should be a last resort. This paper by Dale came out in 2000. It demonstrates the effectiveness of 8-week physical exercise program and physiotherapy in reducing WOMAC scores, as well as increasing the distance walked over 6 minutes. That distance, that improvement on average was 170 meters. That's about 570 feet. That's almost the amount of the distance walked when grocery shopping. So it can make a difference between a patient being able to go grocery shopping or having to have assistance for that. This paper by Go just demonstrates an opposing point of view on knee joint distraction, but not too severely. It demonstrates that there is moderate quality evidence. Most studies, most therapies for osteoarthritis demonstrate mild evidence. Knee joint distraction demonstrates a moderate level of evidence for the benefit of osteoarthritis of the knee. This paper by Jansen and Masbergen came out in 2020 in January, and it just demonstrates the effectiveness of preserving the knee joint through knee joint distraction. This slide just demonstrates the difference between knee joint distraction surgically and non-surgically. Surgical knee joint distraction of 5 millimeters for 6 weeks, followed by 12 weeks of rehabilitation, demonstrated a drop in visual analog scale by 27 millimeters. Cox flexion distraction decompression of the knee of 12 millimeters to 36 millimeters, so the preset settings of 0.5 inches to 1.5 inches. The mean number of treatments was 5.3 treatments over an average of 3 weeks. This is an x-ray of a patient of mine. This x-ray here was taken 3 years before he came to see me. He had this knee replaced in 2015. He came in to see me in 2018. His pain in his left knee was between a 4 and 7 out of 10, consistently a 4. His right knee at the time was a 2 out of 10. So he said his right knee surgery wasn't 100% successful. It was maybe 80% successful. In the beginning, we did not do any treatment to his right knee. We only treated his left knee. The next x-ray shows what his left knee looked like right before we started to treat him. And this was an x-ray done just recently because of complaints of right knee pain and discomfort. So when we look at the chart, on his first day of treatment, we treated the left knee only, and he felt immediate improvement. But he said the right knee was sore. He came in for his second treatment 4 days later. There was no change. He said the treatment lasted only a few hours. We did the treatment again, and he felt better. Again, he noticed after the treatment, when he was walking out of the office, that his right knee was a little more noticeably sore than before coming in for treatment. After his third treatment, that was on day 7, his left knee was doing a lot better. His right knee, he was noticing more discomfort and some pain. His fourth treatment was on day 11, and his left knee, he said, was 75% better. His right knee, he noticed stiffness, soreness, and the pain was worse than in the left knee. He rated the pain now in his right knee as 7 out of 10. So we did both knees on that treatment, and he walked out of there feeling fantastic. He came in 3 days later. His left knee was a 2 out of 10. The right knee was back to where it was before. So again, we did both knees. He felt much better when he left. So by the time we got to day 142, so if you go down to the third last row there, both knees were rated a 1 out of 10. So that's just over 4 months of treatment, almost 5 months of treatment. So he felt he was good enough. He didn't need it. He went on a trip. After the trip, his wife said he started complaining that his knee was bothering him, but it held up during the trip. So it took him almost 6 months to come back in and see me. And we began treatment on his right knee. His left knee has not been touched since. Just this past few weeks, he's been coming in again, so he did take time off again. Again, not a compliant patient in terms of coming in as recommended. He was contemplating going to see a knee surgeon. His wife convinced him to come back in for treatment. We've been treating him, and it is doing better again. We'll see how the treatments go ahead. But this was treatment to his surgically replaced knee. In this next slide here, this was a 90-year-old patient. He complained of pain, 8 out of 10. I don't think he's a candidate for surgery. And he hadn't seen a surgeon yet. His doctor doesn't want him to get surgery. His doctor wants him to continue with the therapy. He could only achieve 80 degrees of flexion and 15 degrees of extension. He had pain that was palpable above the femoral condyles, both medially and laterally, negative valgus varus. He had mild pain with Apley's compression, but he had positive patellar compression. And this is his lateral view, so you can see the amount of osteoarthritis that has developed in the patellofemoral joint. But after 7 treatments, he had no pain except when he used the stairs. He would rate it a 5 out of 10. His range of motion didn't improve. We started using K-tape as well as the treatment, and he comes in now once every 2 weeks, and he doesn't complain of pain, he just complains of stiffness now. This was a 47-year-old patient. He came in after running. So 2 months prior to coming to my office, he had been running, jogging, and felt a pain in his knee. By the time he came in to see me, it was an 8 to a 10 out of 10. He plays recreation league hockey. He's a goalie, and he works in a factory standing all day. He had palpable pain and swelling over the medial aspect of his knee and over the medial collateral ligament. The patella was tender, the adductor tubercle was tender, and the insertion of semimembranosus was also tender. He had a fullness, Baker's cyst, in his popliteal fossa, and the pain was with weight bearing and turning in bed. Valgus stress test was positive. Apley's and McMurray's was also positive. Flexion he could only attain was 110 degrees. Extension was no problem except with weight bearing. We did Cox extremity adjusting at 1 inch, 10 repetitions. The first visit he walked out with 50% improvement. Second visit he came in, he said he was a 5 out of 10. After 10 treatments over 5 weeks, he was back in net, no complaints, no pain. So I hope that these were case studies that we can relate to, and use in your practice. I do invite you to ask questions. Email me, my information is right there. I don't know where I got this picture from, but I do like it. It does say a lot about what we come across with our patients. But text me, email me, call me with any questions you have. I would love it if more people got involved with researching the treatments for the knee, the hip, and the developing treatments for the shoulder. Thank you for providing me this opportunity to describe what I'm doing, and I hope to demonstrate these therapies for you. Closer, look up here. Is that okay there?
Mm-hmm.
Feels okay?
Mm-hmm.
Tender there?
A little bit.
Got it. You can get all the way to rectus femoris, get the psoas out of doing this.